As Izzy mentioned, there's three different aspects we're going to cover in terms of these methods sections. And we've looked at statistics, and your next port of call might be health economics. So I'm going to talk to you about how to work with your health economist and the sorts of things we might be looking at. If you've worked with a health economist before, or if you haven't, what are the sorts of things we might be doing? So health economists work on a broad range of things. We explore resource use in healthcare. We conduct resource use and cost analyses from different perspectives, which means we think about whose costs are we capturing. So do we take an NHS and social services perspective, for example? Do we capture costs to the patient, costs to government, which might include healthcare and education, for example? Or do we take a societal perspective and capture all costs regardless of who bears them? We might evaluate the impact of interventions on health-related quality of life or well-being, using generic measures, very often such as the EQ5D, but also using the SF6D or ICE-CAP, which is a measure of capability well-being. We might evaluate the impact of interventions on days of lost productivity or lost education for children, for example. Very commonly, we conduct economic evaluations, for example, cost effectiveness analyses, both alongside clinical trials or perhaps as standalone studies and modelling work. We conduct budget impact analyses where we're looking at the affordability of an intervention. So in a cost effectiveness analysis, we would be looking at value for money, whereas in a budget impact, we're looking at the sort of total expenditure related to a new intervention and assessing its affordability. And finally, we might collect information on preferences using discrete choice experiments and look at people's willingness to pay or assess people's willingness to pay. So there's a very broad range of things we get involved in. And here's a few examples of publications from our group, ranging from cost effectiveness analyses alongside a clinical trial, estimating quality adjusted survival benefit and cost effectiveness, then looking at health related quality of life, some systematic reviews, patient preference elicitation studies, meta-analyses, and budget impact assessments. So a whole range of things and range of different ways that a health economist might contribute to your grant application. But I guess the most common way, and if you've worked with a health economist before, it's a good chance that they were involved in an economic evaluation. And if you submit a grant application, it may be that you include an economic evaluation in that study. So why do we need this? What's the point of all this? Well, if we think of the UK context and the aim of the NHS to secure the provision of comprehensive, high quality care for all those who need it, regardless of their ability to pay or where they live. So this is quite an ambitious aim. And to do all of this, even trying to provide a comprehensive service for everybody, given our limited pot of money, the limited resources we have for healthcare, trade-offs need to be made. And so we need to make choices about what we fund and what we don't fund. And economic evaluation is a systematic and explicit way of making choices in healthcare. And so what is it? Well, the aim of economic evaluation is to maximize the health gain with the available resources. So it's about maximizing your bang for your buck and getting the most out of our finite pot for our population. And to do this, we want to compare the costs and outcomes of new and existing interventions. And the data from that can come from a clinical trial or from a modelling study. And the classic textbook's definition of an economic evaluation is that it's the comparative analysis of alternative courses of action in terms of both their costs and their consequences. So we're thinking about inputs and outputs, what costs we put in and what outcomes we get out. And when we think about our economic evaluation, there's three key sort of design questions. There are others, but these are three really important aspects to consider. Firstly is the comparator. So an economic evaluation never just looks at a new intervention. It's always a new intervention compared to something else. And that something else is likely to be usual practice. So what's done at the moment? So that could be the current market leading drug for treating condition X. It could be the current way of doing things, the current physiotherapy program. It could be do nothing if we don't currently have a treatment available for a condition, or it could be palliative care if that is the current standard. But it's really important to choose an appropriate comparator, which is likely to be the thing you're wanting to replace with your new intervention. The perspective is also really important. So this is about whose costs and benefits are we capturing. And in here in England, NICE is keen for us to take an NHS and personal social services perspective, so a health and social care perspective. But if there are clearly consequences beyond the healthcare, in terms of time off work, for example, then we can also present a second perspective, a wider perspective from a societal point of view, capturing all those additional things. And then importantly, how long do we capture these costs and benefits for? What is the time horizon of our evaluation? So if we're looking at a condition, I don't know, a new antibiotic for a urinary tract infection, something that lasts a fairly finite, short period of time, we may only need a short time horizon, just a month or two. Whereas if we're looking at an intervention which has much longer term impacts, so the impact of surgery, the impact of a hip replacement, for example, we're hoping the patient's going to see the benefit of that over a number of years. So we need a long time horizon to capture all the consequences of that procedure. And if we've got a difference in mortality between arms, then we really should be looking at a lifetime time horizon. So they're really important details to decide for your economic evaluation, and also to be explicitly state in your application. So working with a health economist, how can we do this to ensure that your application is as strong as possible with respect to the health economics components? Well, just as Natalia was saying about contacting your statistician early, also contact your health economist early. Probably want to get your statistician involved first, but fairly soon after that, if you think there's important consequences for costs and outcomes, you should be thinking about whether a health economics component is important for your study. And if we are involved at the start or from the early days, we can determine the most appropriate methods for collecting data on quality of life, resource use and costs, and embed those into the application and really integrate the health economics into your proposal and cost our time appropriately. And also if there's any piloting of data collection methods, or if you're doing a feasibility study, any feasibility work before your main trial, again, getting health economists involved early to help with those aspects and test things out, test the health economics methods and data collection tools out for your full trial. I know it can be difficult to find statisticians and health economists, but your RSS can help you, point you in the direction of potential health economists who may be able to help, or groups that have particular interests in the type of work you're doing. So, you want to work with your health economist effectively together to make sure the health economics components of your grant application are prepared to a high standard. And this is very much a collaborative process. But you want to ensure, just like the other aspects of your proposal, that the economic question is clearly stated in the objectives. It might be one of your secondary objectives. Ensure that the question and choice of approach are justified. Ensure that the proposed data collection and analysis is feasible, that it can be completed within the time frame and budget of the grants. and that it won't be too much of a burden on patients. So there's often this sort of we have to compromise between all the data we want to collect and then thinking about the burden on patients and whether they're actually going to fill in this great long form. And we may need to compromise or think of different ways of collecting data to reach a happy medium. We want to ensure that we adhere to best practice guidelines and agree appropriate milestones and deliverables. So thinking about the case study that Natalia introduced, this was a HTA call for applications to evaluate the clinical and cost effectiveness of physical exercise for treating depression in adolescents. And this call required applicants to submit plans for a 3-arm randomized controlled trial to evaluate high and low intensity physical activity, physical exercise, compared to no exercise. And we're going to assume that you're designing the economic evaluation to run alongside this trial, but the points we cover would be transferable to other types of health economic study. So I'm going to go through various steps and what you'll need in terms of health economics to put in the different sections of your application, thinking about this example. But what's really important, and I think Natalia touched on this, is that you're the expert. You've obviously got far more clinical expertise than we have, and you know the literature, the clinical and scientific literature related to your topic. So be prepared for lots of questions. You saw in the little video that the clip that Natalia showed before she started that, you know, the statistician had a lot of questions. They can't just come up with a number. And it's very much the same for the health economists. We need to understand your patient group and the likely patient pathway, potentially how things will change for patients over time. How will the intervention impact on them and how quickly and over what time period, which helps us to determine when we need to capture outcomes. So it's very much, the first thing we'll do is ask you lots of questions in order to help design the health economics aspects. So for the plain English summary, you need to explain in lay terms the health economics aspects of the proposal. So if it's a cost effectiveness analysis, you could say you'll be looking at value for money of the new intervention. If you're doing a budget impact analysis, you could be talking about the affordability of a new intervention. And as the case study was a cost effectiveness analysis, they stated that the aim of their research was to find out whether exercise is an effective treatment for young people with depression and whether it is good value for money for the NHS. Now, people commonly try and talk about cost savings when they're talking about new interventions. A new intervention doesn't have to be cost saving to be cost effective, and it may well not be cost saving. So don't confuse that. And also don't talk about cost savings as a benefit. We think about the costs and the benefits in terms of outcomes and impact on patients as two separate aspects. So that's what needs to be the sorts of things that need to be covered in the plain English summary. In the background section, you need to explain why the research is needed and why there's a need for the health economics aspects of the work. So you need to talk about the burden of disease, the numbers and the cost to the NHS or society, and describe the existing evidence in the area. So are there relevant estimates of costs, quality of life, or even existing cost effectiveness data? So for the case study, we'd be thinking about what is the burden of depression in adolescents? What are the annual healthcare costs associated with treating depression in this population? What's the quality of life impact of depression? And what are the current treatment options and how cost effective are they? We want to see whatever health economics evidence presented in a background section, even if it's just to say that there isn't any data. And don't get sucked into citing evidence for the wrong population. If it's not a relevant population, you're better to say that there's no health economic evidence for this group rather than presenting data that's not relevant to the case you're making. For the aims and objectives section, you want to clearly describe the aim or objective of the economics component, which could be a primary aim or a secondary aim. So in the case study, there was a clear objective to estimate the cost effectiveness of high and low intensity exercise programs compared to an active control. If you've got a health economic strand, you want an objective, an explicit objective around the health economics. So if you don't, it looks odd if economics suddenly pops up towards the end of your application and it wasn't mentioned in your aim or objective. It doesn't look very well thought through. So make sure things tally up. You've got an objective and then you've got your methods for that section later on. Clearly, the methods is a really important section where you'll need to describe your health economics methods and analysis. So you want to be describing, as I mentioned earlier, your design, so your comparator and your time horizon and your perspective. You'll also be describing what information on health outcomes you're going to collect and at what time points that's being collected. And as I said earlier, that'll very much be a discussion with you about what are the key time points when we think things might change for patients and when they might differ between the groups. And you may well be collecting outcome data for the economic evaluation at the same time as your clinical outcomes, because it may be that you're expecting when the clinical changes are expected, that's when you're expecting the health outcomes changes. But we need to understand that patient journey in order to determine the appropriate time points. You're going to collect information on resource use and costs. So again, thinking about your perspective and what costs are you going to capture, what resource use are you going to capture. So healthcare resource use and then any wider costs, informal care, family helping to look after patients, any productivity costs. And then for each item of resource use that you capture, such as a day in hospital, you then need a unit cost for that day in hospital. So where will you get those from? And thinking about how all this data will be collected. So from patients, from questionnaires, from case report forms as part of your trial, or from using routine data sources. And so you need to spell out how all this data will be captured. And remembering that there's patients in all of this and the burden on patients, particularly at times when they're feeling not very well. So thinking about, the burden of all the different instruments across the study as a whole, and what you're expecting patients to do and whether that's reasonable. And clearly that's an important thing to be talking to your PPI group about. So in the case study, we would describe that we're capturing outcomes in terms of quality of life using the Euroqual EQ5D 5-level questionnaire at baseline and at each follow-up visit. And we're going to convert that into utilities using the current recommended methods using UK population valuations. We may also want to capture some disease or symptom-specific outcome measures. And then what resource use and costs are we going to capture? So the intervention, additional healthcare resource use, primary and secondary care, medications, and then other resource use, time off work or education, carer burden, over-the-counter medications, perhaps from questionnaires, and also collect these things at each follow-up visit. We want to be clear that the health economics work will adhere to best practice guidelines. So NICE produced guidance in their health technology evaluations manual describing, for example, that they prefer us to take an NHS and personal social services perspective, but also giving guidance about when a societal perspective might be appropriate or an additional perspective of a societal perspective might be appropriate. There's some particular guidance for public health. And we can also follow the CHEERS guidelines, which are reporting guidelines for health economic evaluations. So it's good practice to say that these guidelines relevant to our country of interest will be followed. So in the methods and analysis section, we want to describe when the analysis will be undertaken. Will there be any interim analysis, for example, and exactly what will be done? So I've said we want to state our perspective and time horizon. How will we handle missing data? This can be a particular problem for health economics, particularly with our cost data, when you think we have a lot of different variables, a lot of different resource use items that we want to add up and cost and add up. So it's not just one outcome measure, is it missing or not, but we might have, up to 100 different resource use items, and we cost each of them and add them all up. So if any one is missing, then our total cost is missing. So we have to think quite carefully about how we handle missing data in economic evaluations. Need to think about how we're going to source our unit costs. Are you going to use national sources? Are they available for all the types of things you want to cost? If your time horizon is beyond 1 year, we want to discount our future costs and benefits back to the present day. So we need to say we're going to do that. Think about how we're going to report our costs and outcomes, how we're going to consider uncertainty, and how we're going to present our results. And particularly if there's a difference in mortality between the groups, then we may want to think about a longer time horizon, say, than our clinical trial. So we may want to do some extrapolation beyond the end of the trial to a longer or lifetime time horizon. And it's also good practice to specify the software that we're going to use. So in the case study, we were taking an NHS and personal social services perspective. We've got a minimum of 1 year follow-up within the trial, but we could consider building in provision for longer term follow-up using some modelling. May state that we're going to use multiple imputation to handle missing data, state the discount rate. Are there any subgroup analyses that we want to consider? And what do we want to look at in sensitivity analysis? Perhaps the impact of adherence or uptake. So when we thought of all that, our health economics methods in our grant application might look something like this. So we're conducting a within trial analysis, estimating the cost effectiveness of high and low intensity exercise programs compared to an active control. So there are 3 groups from an NHS and personal services perspective, and randomization to 1 year. So that's our time horizon and perspective. We state the primary outcome will be quality adjusted life years, how we're going to estimate that using the EQ5D, administered at baseline 6 and 12 months. And we say that the resource use data collection will be included into the trial case report forms for the exercise programs and collected at each follow-up from participants. So we've clearly stated what costs and what outcomes we're going to capture and at what time points. And then we've got a paragraph more about the analysis and how we're going to handle and use that data. So we say we're going to have unit costs largely from nationally published sources attached to the resource use and to calculate total costs. Responses to the EQ5D will be assigned valuations according to NICE guidance at the time of analysis and combined with survival to calculate QALYs gained per participant. Missing data will be handled using multiple imputation methods. And then our analysis from average costs and QALYs associated with each group, the incremental cost effectiveness ratio, the ISA, will be derived, producing the incremental cost per QALY gained with each exercise programme compared to active control. Analyses will be conducted in Stata. Results will be expressed in terms of a cost effectiveness acceptability curve, which indicates the likelihood that a high or low intensity exercise programme is cost effective for different levels of willingness to pay for health gain. So this is about how much are we prepared to pay for an additional unit of health gain. And that's presenting that information helps decision makers to assess whether an exercise programme is likely to represent value for money for the NHS. Another important aspect will, of course, be budget. And most health economists are funded piecemeal on a project by project basis, so we need to fully cover our costs. And so within a Well, here we've got an example of a 5-year Wellcome Trust programme grant, including a complex economic evaluation. This would typically include the lead health economist's time for 5%, 10% for the duration of the study, and then a junior researcher's time for the key chunks of time when health economics analyses are active. So that might be a chunk of time at the beginning, designing data collection forms and getting things set up, and then a chunk of time towards the end for the actual analysis. Would include money perhaps for conferences, training, any software, and travel. And so it can add up. But without proper funding and proper amounts of time, we can't do a thorough evaluation. You want to think about how you're going to report and disseminate your findings. It's likely that you'll probably have a separate paper for the health economics compared to the clinical results, just because there isn't space to adequately describe the methods and results in enough detail if we try and do both in a single publication. But sometimes that's the case. And obviously we need to consider where publication costs will come from. If you'd like to know more about health economics, Southampton and Oxford both run a number of courses introducing health economics, and you'll find courses run by many other health economics groups across the country. If you're doing a fellowship, for example, and perhaps not including health economics in your current study, you might think about a sort of one-day introduction to health economic evaluation as part of your training program, thinking about your next steps and your future career. That might be useful, even if it's not part of your current study. So, in summary, health economists can make a variety of valuable contributions to your grant application. Do contact a health economist early in the grant writing process to maximise these benefits, and contact your RSS for help finding a health economist if you're struggling. And really work collaboratively with them to ensure that you get the best design and get your health economics fully integrated with the other elements of the application.